Welcome to this comprehensive lecture on large intestine anatomy and function. In this presentation, we'll explore the structure, physiology, and clinical significance of the large intestine, a crucial component of the digestive system. The large intestine, also known as the colon, is the final segment of the gastrointestinal tract. It extends from the ileocecal valve to the anus and measures approximately 1.5 meters in length. Unlike the small intestine, the large intestine has a larger diameter and distinctive features including haustra, taniae coli, and appendices epiploicae. The primary functions of the large intestine include water and electrolyte absorption, formation and storage of feces, and housing a complex microbial ecosystem. Now let's examine the three primary functions of the colon in detail. First, water and electrolyte reabsorption. The colon absorbs approximately 1 to 2 liters of water daily, converting liquid chyme into semi-solid stool. This process is essential for maintaining fluid balance in the body. Second, microbial fermentation and vitamin synthesis. The colonic microbiome ferments undigested carbohydrates and produces short-chain fatty acids and vitamins, particularly vitamin K and certain B vitamins. Third, stool formation and storage. The colon compacts waste material and stores it in the rectum until voluntary elimination occurs. Unlike the small intestine, which is primarily responsible for nutrient absorption, the colon focuses on water conservation and waste management. Let's explore the anatomical segments of the large intestine. The cecum is the first segment, a pouch-like structure in the right lower quadrant where the small intestine connects. The ascending colon travels upward along the right side of the abdomen. The transverse colon crosses horizontally across the upper abdomen. The descending colon travels downward along the left side. Each segment has distinct characteristics and functions that contribute to the overall digestive process. The cecum and appendix deserve special attention due to their clinical significance. The cecum is a blind pouch located in the right iliac fossa, measuring about 6 centimeters in length. The ileocecal valve regulates the flow of material from the small intestine and prevents backflow. The appendix is a narrow, finger-like projection attached to the cecum, typically 8 to 10 centimeters long. While once considered vestigial, the appendix is now recognized as having immunological functions and serving as a reservoir for beneficial gut bacteria. Clinically, appendicitis is one of the most common surgical emergencies, while cecal volvulus can cause bowel obstruction, requiring urgent intervention. The ascending, transverse, and descending segments each have unique characteristics. The ascending colon is retroperitoneal, meaning it's fixed to the posterior abdominal wall. It measures about 15 centimeters and is the primary site for water absorption. The transverse colon is intraperitoneal and mobile, suspended by the transverse mesocolon. It measures approximately 45 centimeters and continues water absorption while beginning stool formation. The descending colon is also retroperitoneal, measuring about 25 centimeters. It serves as a storage site where stool becomes more solid as additional water is absorbed. Colonic motility is essential for moving contents through the large intestine. There are 3 main types of colonic contractions. Segmental contractions mix contents and facilitate absorption. Peristaltic contractions propel contents forward slowly. Mass movements are powerful contractions that occur a few times daily, moving contents rapidly over long distances, often triggered after meals. Neural control involves the enteric nervous system providing local regulation, while the parasympathetic nervous system via the vagus nerve stimulates motility. Hormonal control includes gastrin and cholecystokinin, which increase colonic activity, particularly after eating. Water and electrolyte reabsorption is a critical function of the large intestine. Sodium absorption occurs through epithelial sodium channels, creating an osmotic gradient that drives water reabsorption. The colon can absorb up to 90% of the water entering it. Chloride and bicarbonate exchange involves chloride absorption, coupled with bicarbonate secretion, which helps neutralize acidic bacterial metabolites. Potassium handling is complex, with both secretion and absorption occurring. Excessive colonic potassium loss can occur in diarrheal states, leading to hypokalemia. The relationship between colonic reabsorption and transit time is clinically important. In rapid transit, or diarrhea, contents move too quickly through the colon, resulting in insufficient time for water reabsorption. This leads to loose, watery stools and can be caused by infections, inflammation, or motility disorders. Normal transit allows adequate time for water absorption, producing well-formed stools. In slow transit, or constipation, contents remain in the colon too long, resulting in excessive water reabsorption. This produces hard, dry stools and can be caused by a low fiber intake, dehydration, or motility disorders. The colonic microbiome functions as a complex ecosystem. Dominant bacterial phyla include bacteroidetes and firmicutes, which make up over 90% of the colonic bacteria. Fermentation of dietary fiber occurs when bacteria break down indigestible carbohydrates, producing short-chain fatty acids like acetate, propionate, and butyrate. Vitamin synthesis includes the production of vitamin K and certain B vitamins by colonic bacteria. Colonization resistance refers to the microbiome preventing pathogenic bacteria from establishing infection by competing for nutrients and producing antimicrobial substances. Short-chain fatty acids have both local and systemic effects. Local effects in the colon include serving as the primary energy source for colonocytes, maintaining the intestinal barrier, and having anti-inflammatory properties. Systemic effects include butyrate improving insulin sensitivity and glucose metabolism, propionate being metabolized in the liver and affecting cholesterol synthesis, and acetate entering systemic circulation and influencing appetite regulation. The clinical implication is clear. Adequate dietary fiber intake, typically 25 to 30 grams daily, is essential for optimal short-chain fatty acid production. Intestinal gas production and elimination is a normal physiological process. Gas sources include swallowed air, which contributes nitrogen and oxygen, and bacterial fermentation, which produces hydrogen, methane, and carbon dioxide. Typical gas composition includes nitrogen at 20 to 90%, hydrogen at 0 to 50%, carbon dioxide at 10 to 30%, oxygen at 0 to 10%, and methane at 0 to 25%. Elimination pathways include flatus, or passing gas rectally, which occurs 10 to 20 times daily in healthy individuals, and eructation, or belching. Excessive gas or bloating can indicate malabsorption, bacterial overgrowth, or food intolerances. The sigmoid colon has important anatomical and clinical features. Anatomically, it's an S-shaped segment measuring 40 centimeters, located in the left lower quadrant. It's intraperitoneal with a mesentery, making it mobile. Blood supply comes from the sigmoid arteries, branches of the inferior mesenteric artery. Physiologically, it serves as the final site of water absorption and stool storage before defecation. Clinically, it's a common site for diverticulosis, where small pouches form in the colonic wall. Sigmoid volvulus can occur due to its mobility, causing bowel obstruction. It's also a frequent location for colorectal cancer. The rectum serves as a storage site before elimination. Anatomically, it's the terminal 12 to 15 centimeters of the large intestine, extending from the sigmoid colon to the anal canal. It has 3 lateral curves called the valves of Houston. Neurosensory function is provided by stretch receptors that detect rectal distension and signal the need for defecation. Compliance and accommodation allow the rectum to expand and store feces without significant pressure increase. Blood supply comes from the superior, middle, and inferior rectal arteries. Venous drainage occurs through the rectal venous plexus, connecting portal and systemic circulations. The anal canal and sphincter complex control continents. The internal anal sphincter is smooth muscle under involuntary control, maintaining resting tone and providing 70 to 80% of resting anal pressure. The external anal sphincter is skeletal muscle under voluntary control, allowing conscious control of defecation. The puborectalis muscle is part of the levator ani, creating the anorectal angle at approximately 90 degrees at rest. During defecation, this angle straightens to facilitate stool passage. This complex mechanism ensures continence while allowing voluntary elimination. The defecation reflex and voluntary control involve a coordinated process. Rectal filling occurs when stool enters the rectum, triggering stretch receptors. The defecation reflex involves the internal anal sphincter relaxing involuntarily, while the external sphincter contracts voluntarily to maintain continence. Sampling allows the anal canal to distinguish between gas, liquid, and solid. Voluntary defecation occurs when conditions are appropriate. The person voluntarily relaxes the external sphincter and puborectalis muscle, straightening the anorectal angle. Valsalva maneuver increases intra-abdominal pressure, and coordinated relaxation and contraction facilitate stool expulsion. Stool formation progresses from chyme to feces through several stages. In the cecum and ascending colon, liquid chyme enters with about 90% water content. In the transverse colon, progressive water absorption occurs, reducing water content to about 70%. In the descending and sigmoid colon, further water absorption creates semi-solid stool with about 75% water content. Final stool composition includes water at 75%, bacterial mass at 15%, and undigested fiber and other solids at 10%. Normal stool production ranges from 100 to 200 grams per day, varying with diet and individual factors. The Bristol Stool Scale is a clinical assessment tool that classifies stool form into 7 types. Type 1 consists of separate hard lumps indicating severe constipation. Type 2 is sausage-shaped but lumpy, indicating mild constipation. Type 3 is sausage-shaped with cracks on the surface, considered normal. Type 4 is smooth and soft, like a sausage, or snake, also normal. Type 5 consists of soft blobs with clear-cut edges, indicating mild diarrhea. Type 6 is fluffy pieces with ragged edges, indicating moderate diarrhea. Type 7 is entirely liquid with no solid pieces, indicating severe diarrhea. Clinical utility includes assessing bowel function, monitoring treatment response, and facilitating patient-provider communication about bowel habits. Common colonic pathophysiology includes several important conditions. Irritable bowel syndrome is a functional disorder characterized by abdominal pain and altered bowel habits without structural abnormality. It's related to visceral hypersensitivity and altered motility. Inflammatory bowel disease includes Crohn's disease and ulcerative colitis, chronic inflammatory conditions causing diarrhea, bleeding, and abdominal pain. Diverticular disease involves outpouchings of the colonic wall, common in Western populations. Complications include diverticulitis and bleeding. Colorectal cancer is the 3rd most common cancer worldwide, often developing from adenomatous polyps. Screening is crucial for early detection and prevention. Let's review the key takeaways about large intestine structure and function. The large intestine consists of distinct anatomical segments, each with specific functions. The cecum, ascending, transverse, descending, and sigmoid. Colon, rectum, and anal canal work together in the digestive process. Water conservation is critical, with the colon absorbing 1 to 2 liters of water daily, preventing dehydration. The microbiome plays essential roles in fermentation, vitamin synthesis, and immune function. Transit time directly affects stool consistency, with rapid transit causing diarrhea and slow transit causing constipation. The continence mechanism involves coordinated function of the internal and external anal sphincters and puborectalis muscle. Finally, let's consider clinical integration and future research directions. Understanding large intestine physiology is essential for managing diarrhea and constipation, inflammatory bowel disease, diverticular disease, and colorectal cancer screening and prevention. Future research directions include investigating the gut-brain axis and its role in functional disorders, exploring microbiome modulation as therapeutic strategy through probiotics, prebiotics, and fecal transplantation, developing personalized nutrition based on individual microbiome composition, and advancing early detection methods for colorectal cancer. The large intestine represents a fascinating intersection of anatomy, physiology, microbiology, and clinical medicine, with ongoing research continuing to reveal its complexity and importance. Thank you for your attention to this comprehensive overview of large intestine anatomy and function. Understanding these concepts is fundamental to clinical practice and patient care.